Well, good morning, everyone. Hi, my name is Camilo Rueda. I'm a five-year medical student. I'm also I'm a member of the Medical Students Committee, and there I had the pleasure to be the system director of this year. And today, I will presenting you the topic of acute appendicitis, but we will try to offer you a clinical approach in order for you to understand this clearly. So next, please. I have here. Sorry. Okay, well, we will start in with the definition. I know that all of you already have been seeing this a lot in the ER, but it's pretty important for you to understand that the basis of this disease, it will be the inflammation. We will see that later in the pathophysiology. So the appendicitis, it will be an inflammation of the appendix. So it's one of the most common causes of acute abdomen in the ER. And for you to understand this, it's pretty important because it will be an emergency abdominal surgical procedure. So you need to know that this is pretty big, and you need to understand this in order to correlate all the symptoms of the patients in order to provide a good diagnosis. Related with the epidemiology, it will be approximately from 100 per 100,000 persons per year. It will be like the incidence of this disease. Also, it's been declining since the 70s, but there's no any reason for that. Also, it's more frequent in the second and third decades of life, and it's less, obviously, in children. The highest age group, it will be from 10 to 19 years old, and that is the reason why when we are in our clinical rotations, we will see that teenagers are the most consulting people with this disease. Well, regarding the anatomy, it is pretty simple. We know that the appendix is a true diverticulum. That means that it has all the layers of the intestine. So that is the reason why later in the pathophysiology, we will see that that when the mucus is secreted, it will increase the intraluminal pressure because it has all the layers. It's a true diverticulum. So regarding the blood supply, the only thing that you need to know is that the blood supply comes from the mesenteric, from the superior mesenteric artery, and then it's declined to the ileocholic artery and then the appendicular artery. That is the irrigation of the appendix. It's by the appendicular artery that it comes from the superior mesenteric artery. That's all that you need to know. And then we have the lymphatic drainage. We brought this here because you know that in children, and later we will see that, the most common cause of appendicitis, it will be lymphoid hyperplasia. So you need to know that there's some nodules in the intestine that it will secrete all the lymphatic drainage. So that is the only reason why we brought this here. Next. So regarding the pathophysiology, this will be the most important part here, and you need to understand this because when we have a patient, they will always ask for us to explain to them why they are causing or experiencing this disease. So we need to try to explain to them. So the first thing that happens here in the pathophysiology, it will be that the initiation of acute appendicitis, it will happen because of lumen obstruction. Here you can see the potential causes of obstruction. The first one will be obstruction that is related with appendiculitis, that it's like, as you see in there, like poof that it keeps obstructed into the appendix. Also, there's another causes such as calculate or lymphoid hyperplasia that it's the most common cause in children. So that is a question that it happens a lot. Then when we have here the obstruction, we have the progression of the intraluminal pressure. Remember that I told you that the appendix is a true diverticulum, so it has all the layers of the intestines. So it's pretty important for you to understand this because remember that all the intestines keep secreting mucus all the time. So when we have an obstruction here, the mucus will be keep secreting every time, but there's no any place for the mucus to go. So it will increase the luminal pressure. And when increase the luminal pressure, it will cause inflammation. So remember that I told you at the beginning that the definition of the appendicitis, it will be an inflammation of the appendix. So the inflammation, it will be the protagonist in this scenario, because it will cause, after all the symptoms start, the inflammation, it will be the thing that it will cause all the symptoms to the patient. And then it will also cause the complicated appendicitis that we will have, that we'll see that later. So we have here the inflammation, and that inflammation will cause thrombosis. That will mean that when we have the inflammation there, it will also cause that the wall of the intestine, that the wall of the appendix get thrombosis, and after that, the thrombosis, it will mean that we will have less perforated tissue, and that will cause the ischemia. So the main thing here, it will be the inflammation, and it's pretty important for you to understand that okay, the luminal pressure is getting high, it's increasing, but the main thing that happens here, it will be the inflammation, and that will cause a thrombosis, and after that, that will cause the ischemia. So remember that when we have an ischemic tissue, it will be something that it's not working, it's not already with life. So it will get like really, really thin, and when it gets really thin, the necrotic tissue, it could cause a perforation of the appendix. So all that, but it's pretty important for us to understand that, because when we have this ischemia, that means that we have a complicated appendicitis, and it could cause a perforation. And remember that when the appendix gets perforated, it could like liberate all the things that has inside. That means the mucus, the bacteria build up that came from there. So it could also go to another parts of the abdomen, another parts of the intestine, and obviously cause all the tenderness around all the body, around all the abdomen, sorry. So it's pretty important for us to understand this, because when we see this, that it will be the stages of the appendicitis, it will be something for us to understand, like that we need to understand pretty, like we have to keep this on mind so much, because it will be something that they will, when we have on our clinical rotations, if you already rotate for example, general surgery, I know that there is the appendectomy is something that we do a lot. So when the resident of our doctor extirpate the appendix, they will always ask for us in which stage of the appendix it is. So it's really important for us to understand and to see how a normal appendix looks like, and in every stage how it looks like, in order for us to answer the question properly. So the first stage that we have here, it will be the diabetes one. Here you can see the bottom of the slide that some specific characteristics of every stage. So for example, in the first one we have that there is more mucosal edema, and the lymphatic drainage comes down, and obviously the venous blood flow comes down too, and the intraluminal pressure is increasing. So when this will be the first stage. The second one, it will be the phlemonous one, and we will have here the more bacterial infection, and obviously the ischemia, it's getting high. And here we will experience, this patient, it will experience more symptoms such as fever, leukocytosis, and also tachycardia. The third one, we will have the gangrenous one. Here the transluminal pressure, it's so high, and obviously the arterial blood flow, it's going down, and the ischemia, the thrombosis and the ischemia, it's appearing. And here you can see in the image, there are some necrotic parts in the third stage, and it's pretty important for you to understand that, because when you see an appendix, when it's removed from surgery, you should be able to classify it in which stage it is. And the last one, it will be the perforated one, that it's pretty simple to see, because it's a specific part who is already necrotic, so it's really simple to differentiate from the other one. And obviously, it's rupture. Here we have an increase of the intraluminal pressure, necrosis, and obviously a thrombosis of the appendicular artery. Regarding the clinical presentation, we have here that there's something that we call constellation of the symptoms, because they're pretty classic in every clinical, in every person, in every patient that experiencing appendicitis. So we have for the first one, and the most important one, it will be the right lower quadrant pain. That it's a pain that is located on the right lower quadrant of the abdomen of the patient, and it's obviously in the right anterior iliac fossa. Also, we can have anorexia, nausea, and vomiting, and the fever, that it's pretty common. It will be more than 38 Celsius degrees. That will be the constellation, the clinical or classic symptoms. Then we have the atypical symptoms that they are already associated with the constellation that we talked before. So we have indigestion, flatulence, intestinal irregularity, diarrhea, and general malaise. So when we have the patient with the clinical symptoms, specifically the right pain on the right lower quadrant, we need to perform to them all these physical signs. I know that a lot of you already know them because you have been seeing this in semiology, but it's important for you to perform at least these 4 signs, and you need to write it down on the clinical chart that you made them to the patient. Because if you don't write them down, that means that you never perform them. So it's very important for you to do that. So we have the max Born's point, that you know that it's from 1.5 to 2 inches from the umbilicus to the spine, to the right spine. Also, we have the Robson sign, that is when we pressure on the left side of the side of the abdomen, on the lower quadrant, and the patient will reverse pain into the other side, that it will be the right one. And we have the psoas sign, that we need to put back the leg of the patient, and because we will stimulate the psoas, the psoas muscle, and obviously the patient will experience pain. That will be a positive psoas sign. And then we have the obturator sign, that we need to pull up the knee of the patient and try to put them against the abdomen or against the thorax. And the patient obviously will experience pain. Obviously, remember that we need to rotate the leg like from out to inside the body. This is something that we always forget, but you remember that you need to rotate them. Some of the recommendations, remember that the Jerusalem guidelines are the ones who are indicated for acute appendicitis, and here we have 3 specific recommendations. The first one, it would be that remember that we need to individualize all the patients. Remember that not everyone are the same, so we need to check for every patient individually, because remember that we have some people with different age, sex, and race. And now the other recommendation, it would be that the clinical scales, such as Alvarado, that we will see that later, are sensitive enough. That means that sometimes when we have an Alvarado of 8 or 9 points, we mean that we need to perform surgery. There's no anything else that we need to do because they are sensitive enough. And the last one, it would be that we cannot use Alvarado scale or score to check for older adults. Remember that all the older adults has different symptoms in when they experience some of these disease. So here's the Alvarado score. Most of you already know them. Remember that the most important points, it will be the tenderness in the right lower quadrant and the leukocytosis. And depending of the amount of points that the patient had, we will classify them from 1 to 4. We will discharge the patient. From 5 to 7, we will keep the patient in observation. And from 8 to 10, we need to perform surgery immediately. Regarding the laboratory findings, the most important thing here, it will be the leukocytosis, more than 10,000 cells per milliliter. It's important for you to understand this, because if the patient doesn't have leukocytosis, it's pretty unlikely that it has appendicitis. Remember that there is an inflammation of the appendix, and remember that this is how the body expresses itself, the inflammation. And also, remember that there was a bacteria buildup, and remember that what it helps in the body with the bacteria, it will be the neutrophils. So we will have more than 75% here. The CRP, it will be pretty high in necrosis appendicitis, but in the other one, it will be positive, more than 40 points. And remember that it's pretty unlikely to find appendicitis without leukocytosis. So when the WBC, that it will be the blood, the white blood count, it's normal, it's pretty unlikely that we have appendicitis. Here it says that the suspected diagnosis of acute appendicitis is a must to have a WBC high. Regarding the imaging, we have here the ultrasound, that it's the most common one. Here in our context, we use this a lot because we don't have the access to another imaging diagnosis helpers. So here on the ultrasound, we will see the double wall thickness is the most common finding. Here you can see on the first one, on the left one, you can see a normal appendix, and in the other one, you can see a double wall thickness appendix. So it's pretty easy to see, to differentiate one from the other one. The other is when we're performing the ultrasound, the patient will experience the pain. We can also see the appendiculate, we can see more echogenic, and we can see fluid in the area. And when we have abdominal CT, we can see here also the double wall thickness, obviously clearer than before, than the ultrasound. We can see a wall thickness. We can see the periappendiceal fat straining, that it's pretty related with the mesoappendix. The appendiceal wall encasement, it's something that it's harder to see, and also we can see the appendiculate. But here, the most important thing for you to understand is that you can see the double wall thickness and the wall thickness in the abdominal CT. And the treatment, remember that we will treat general diseases. So when we find, or when we receive a patient in the ER services and we diagnose appendicitis, we need to perform, seeing the symptoms of the patients. When they became, we need to try it in our mind to check in which stage it is. So when we do that, we can classify it in which state it is, and we can perform and give a treatment to the patient. So in this case, when we receive a patient that it has less than 6 hours of the pain of the initial of the symptoms, we will classify the patient in a dermatose stage, and here we can find gram-negative bacteria or anaerobic bacteria, and we would need to provide them antibiotic. In this case, the choice, it will be the Amoxicillin from 1 to 2 grams per day, and the treatment, it will take up to, from the patient starts, it needs to last 24 hours. When we have the second stage, that it will be the Phlemonous one, here we can find another type of bacteria, such as E. coli, Klebsiella, Streptococcus, and here we can use ceftriaxone plus metronidazole, or we can also use amoxicillin. But remember that here the patient is pretty symptomatic. So, and perhaps the most thing that perhaps when the surgical teams check the patient, they will say that perhaps they need to perform surgery. So when they need to perform surgery, you will see that they are sometimes requesting for a prophylaxis with antibiotics. So we can, since we diagnose the patient and we are starting, for example, the ceftriaxone, we are already like speeding up the process for them to, okay, it's already had the antibiotics, we can schedule the surgery later. The last one, it will be the gangrenous or the perforated appendix. Here we will have an ESBL risk pretty increased. So here the choice, it will be also ceftriaxone and metronidazole, but we can also use piperacillin tazobactam from 4 and 0.5 grams per every 6 to 8 hours. And here the treatment duration, it will be up to 10 days. Remember that there's a specific scenarios where the ESBL it's increased. So for example, in the second stage, we can use ertapenem, and in the last one, we can use imipenem or meropenem. But remember that here in our society, we don't have all this carbapenemics, so we usually always use meropenem. And finally, we have here some recommendations for you to check and have in mind. So the first one, it will be that the diagnosis is based on the association of the clinical semiology. That means that you need to perform the clinical signs. It's a must to perform them. And also we have the clinical examination that it's compatible with the appendicitis. Also, we can have the findings of laboratory that it will be the leukocytosis is a must. And then the radiological diagnosis that it will be the ultrasound in our case. Then we have here that the current evidence from the different studies demonstrates that laparoscopic appendectomy, it will be the most effective treatment. It's really important for you to understand this because most of the all the appendicitis needs to be they need to a surgery because at the end of the day the appendix can gets perforated if we do not perform the surgery. Remember that the first thing that we do as general doctors, it will be make the diagnosis and then request for the surgical team to validate the patient, and they will decide. But from our end, we need to make sure that the patient receive all the needs that they have. And specifically, we need to start the antibiotics treatment in order for the surgical team to perform the surgery later. So that will be it. Thank you so much for listening to me.
Thank you so much, Camilo, for that interesting presentation. Appendicitis, as we all know, it's a day-to-day pathology, and making sure we have it clear, we know how to identify it and how to treat it, it's very, very important. So now we move on with clinical approach to the patient with acute pancreatitis by Lina Vasquez.
Hello, good morning. I introduce myself. I am Lina Vasquez Hernandez. I am a student 8th semester. In this morning, I am going to talk about clinical approach acute pancreatitis. Acute pancreatitis is a common inflammatory process that affects the pancreas. It's characterized clinically by abdominal pain, elevation of the levels of pancreatic enzymes, and radiologic evidence. A number of conditions to induce this disorder, but the pathogenesis is not very fully understood. For establish the definite diagnosis, the table is the important, is the reason of the conference. The establish the diagnosis requires at least two of the following three criteria. First is the abdominal pains consistent with acute pancreatitis. Biochemical evidence of pancreatitis, amylase, or lipase serum level for upper more than the reference limit. 3, confirmatory findings from abdominal imaging used contrast in HCT. In annual incidence of acute pancreatitis is approximately 50 cases per 100,000 populations. In United States, approximately 3,000 of the cases are severe. In Colombia, the main etiology is gallstones, followed by excessive ethanol intakes. Approximately 20 and 30 patients they have the severe form of the disease, and mortality in Colombia rates reaching out 35%. The pathogenesis, there are various causes, but in this conference we are going to focus in the obstructive cause. we will know when the patients tell you a history of the biliary colic or established biliary obstructive pathology. This image shows a cholecystolithiasis. These are gallstones measuring less than 5 millimeters that migrated to level of ampoule of the barrier of the sphincter of Oddi, obstructing the pancreatic duct, and the enzymes not allowed to excite. The intrapancreatic ductal pressure increase, and there is a fluid accumulation with digestive enzymes. In this moment, the enzymes be deactivated, but there is one not deactivated. This is a pancreatic lipase. To act the pancreatic tissue, occasion fat necrosis. In this moment, my fibroblasts, leukocytes, pro-inflammatory cells will arrive. Cause interstitial edema is accumulation of the fluid, consequent vascular insufficiency, and subsequent ischemia, finally. Where the main etiology is gallstone, follow ethanol, RCP, idiopathic, drugs, autoimmune pancreatitis, and anatomic dysfunction. Okay, in clinical features, the main is abdominal pain. This is half acute onset, is constant, severe, epigastric, and left upper quadrant abdominal pain. In some patients, may be also a right upper quadrant, and 50% of patients radiates to the back, increase with intake. In 90% of the patients associated with nausea and vomiting, is the severe cause is the fever, dyspnea, and hypotension in 5 and 10% of the patients. The Revis Atlanta classification divided into 2 types. The first type is interstitial edematous pancreatitis, is an enlargement of the pancreas due to inflammatory edema. Acute necrotizing pancreatitis is a necrosis of pancreatic parenchyma and peripancreatic tissue, which may be sterile or infect, is the 5 and 10% of the cases. Okay, the severity based on the presence or absence specific complications is divided in mild is 85% of the patient is absent or organ failure, and no local or systemic complication. In moderately severe, transient organ failure less than 48 hours. The local complications include peripancreatic fluid and collection and necrosis. Severe is the 20% of the patient present a persistent organ failure more than 48 hours, and is defined by modified Marshall score 2 or more. Okay, in this scale, modified Marshall scoring system for organ dysfunctions. This scale divided 3 systems: the main cardiovascular through systolic blood, renal system through serum creatinine, and finally the respiratory system. A score of 2 or more in any system defines the presence of the organ failure. We centrated when the patient score is 2 with negative 90, not fluid responsive, and renal serum creatinine is 1.9, continue 3.6. The diagnosis is physical examination is very important, very depend upon the severity to the acute pancreatitis. In the patients can be present altered mental states, have a fever, tachypnea, hypoxemia, and hypotension. The patient presents ecchymotic discolorations. In the region, the periumbilical region is the Cullen signs, and the flank lung is a Gray Turner sign. The findings such as a retroperitoneal bleeding indicated to a pancreatic necrosis. In laboratory, it's very important pancreatic enzymes, the serum amylase, rise to 6 to 12 hours, return to normal within 3 to 5 days, given the half-life of the serum amylase. Some patients, I missed the definite diets may be seen in other conditions. In serum lipase, rise in 4 to 8 hours, returns to normal within 8 to 14 days. No specific elevation of lipase have also been reported. Is superior of the serum amylase for the sensibility and specificity. The laboratory for is pancreatic enzymes, hemogram, the presence of the leukocytes, alteration of the hematocrit, and urea and creatinine is the increased kidney failure prerenal ions, and glucose is increased, arterial gasometry for respiratory failure, metabolic acidosis, and liver enzymes is important for the fatigue, and lactose dehydrogenase increase. In this first image, the chest radiographies, we observed the right upper pleural effusion. In second abdominal radiograph is a sentinel loop signs. In the abdominal ultrasound, we do this when the patient suspect of the biliary chaos. Contrast enhanced abdominal computer tomography. The first image, we can observe a normal pancreas. The second picture, we are see heterogeneous appearance of the pancreas and peripancreatic forest trending. In theory, is a pancreas enhanced homogeneous, but there is evidence of the peripancreatic necrosis. The structure is loose. The BISAP score is better than Ranson score, but at this moment, the laboratories allow the results, but abnormal mental status, SARS, defined 2 or more of following, and patient array imaging study. 8 points lower mortality, the 3 to 5 points higher mortality. This is a scoring system, is a Balthasar tomography criteria. This is findings of the UNHEC CT. For example, A is a normal pancreas, is a punctuation score is a 0. B, a focal or diffuse enlargement of the pancreas, the score is 1. C, peripancreatic inflammation with intrinsic pancreatic abnormalities, score is 2. D, intrapancreatic or extrapancreatic fluid collection, the score is 3. And A, 2 or more large collection of cases of the pancreas or retroperitoneum, score is 4. Okay, this is a sample, it's a collection, Balthasar grade D, is a accumulation of fluid collections, and 3 points. Pancreatic necrosis greater than 50%, say 5 points, 6 points, sorry. High severity index, 9 points. Okay, finally, the recommendation is the main cause is gallstone, followed by ethanol intakes. The diagnosis is clinical, talking of the characteristics, abdominal pain, the elevation of pancreatic enzymes, only with these 2 criteria, and it be considered acute pancreatitis and will confirm the diagnosis images. The possibility of the organ failure in the patient is analyzed, knowing when to treat. Thank you for paying attention.
Well, identifying pancreatitis is something really important for us as physicians. So thank you so much, Lina, for that amazing presentation. Now we're going to have Nicole Monsalve with Medical and Surgical Management of Acute Pancreatitis.
Acute pancreatitis is one of the most common gastrointestinal conditions that results in hospital admissions in the United States. Consequently, the incidence is from 110 to 140 per 1,000 population in the United States. Hi, my name is Nicole Monsalve, and in this presentation, I'm going to talk about the medical and surgical management of acute pancreatitis. First, I'm going to talk about the medical management, which is divided in three main steps. First, the fluid resuscitation. Second, we have the pain control. And third, the nutritional support. Consequently, I'm going to talk about and I'm going to indicate the surgical management of acute pancreatitis, such as the ERCP, the cholecystectomy, and finally about the cholecystectomy. The first step of the medical management of acute pancreatitis is fluid resuscitation. This is a really important step because it's the only effective treatment in acute pancreatitis in the first 24 hours after the diagnosis is made. Consequently, we're going to have patients with different clinic symptoms such as vomiting, peripancreatic fluid collections, nausea, and edemas. So we need to campaign with this fluid treatment to avoid any complications that the patient might have. According to different guidelines, different experts, the indicated for this treatment are the isotonic crystalloid formulations, such as the lactated Ringer solutions. The dose for the treatment is from 5 to 10 milligrams per kilograms per hour until the goals are met. The goals for this treatment are heart rate under 120 beats per minute. Also, the mean arterial pressure between 65 to 85 milligrams per mercury, the urine output under 0.5 to 1 milligram, and finally, the hematocrit between 35% to 44%. Now, the second step is the pain control. Well, as we all know, the abdominal pain is the predominant symptom in acute pancreatitis. So we have to control this pain because the patient might have an hemodynamic instability according to this. According to the guidelines, the analgesics indicated for this treatment are the intravenous opioids, such as the hydromorphine and fentanyl. But we need to take into account that the fentanyl might depress the respiratory function, and we need to keep monitoring like the vital signs to see if there is like any change in these symptoms. The dose for bolus for both of these analgesics are from 20 to 50 micrograms with 10 minutes of a low gout period. The third step for the management of acute pancreatitis is the nutritional support. For this, we need to consider that all the patients with several acute pancreatitis are considered with a nutritional deficits. And we have for this treatment 3 options. First, we have the oral nutrition. Well, this depends on the severity of the patients, but it's indicated only if the patients do not have any symptoms such as absence of ileus, nausea, and vomiting. And this treatment can be initiated early, like under 24 hours after the diagnosis is made. And it's important to start this treatment with a low residue, low fat, and soft diet. For second options for this step, we have the enteral nutrition. This is the most recommended nutrition for patients with moderately severe and severe acute pancreatitis. And it's important to start this step with a polymeric formulation at 25 cc per hour, at least 30% of the calculated daily requirement in the patient. And finally, the third step is the parenteral nutrition. This is indicated only in patients who do not tolerate the enteral feeding, or if the target of rate of enteral feeding is not achieved within 24 to 85 hours. And when, like I said, the enteral nutrition is the preferred for this treatment, especially in patients with moderately severe and severe acute pancreatitis. And why is this? Well, here we're going to have different advantages, such as, first, this helps to maintain the intestinal barrier. Second, prevents the bacterial translocation from the gut. And third, finally, we have this avoid any complications that may be associated to the parenteral nutrition. But we need to take into account that the patient might have any symptoms that shows that the enteral nutrition is not being tolerated, such as abdominal pain, vomiting, blurring, and diarrhea. And all of these symptoms resolves if the feeding is held. And in these cases, it's important to start our second options, which is the parenteral nutrition. Now, we have other therapies with no role in acute pancreatitis, such as the antibiotics. Well, 30% of the patients with acute pancreatitis have extrapancreatic infections. And in these cases, where we suspect of an infection or we confirm, we can start with antibiotics. But it's not indicated to start this treatment if as a prophylactic treatment. I mean, if there is no any suspect or any confirm of this infection, we do not start with antibiotics. With the antifungicals is a little bit like the same, because this is not indicated as a prophylactic treatment. It's just indicated in patients where we suspect or we confirm presence of fungal organisms. And according to different studies that have been made in the last years, we have that these cases have increasingly and a 30%. But according to these studies, it's not associated with the higher mortality in these cases. Now we continue with the monitoring, which is important to do it like in all the management in patients with acute pancreatitis. And here we have the oxygen saturation, which needs to be like under 90%. The blood gas analysis, that it's important in patients with the oxygen saturation under 90%. The urine output that needs to be measured early. The fluids needs to be to maintain the urine output under 0.5 to 1 cc per kilograms per hour. The electrolytes need to be monitored frequently, especially in the first 48 to 72 hours. The serum glucose levels need to be also monitored early, and the urinary bladder pressures is indicated in patients in the ICU department. And this is important because it's to keep the monitoring for a potential abdominal compartment syndrome. Now we continue with the surgical management of acute pancreatitis. And here we have first the endoscopic retrograde cholangiopancreatography. This is a procedure that is indicated in all the patients with gallstone pancreatitis. And it's important to do this procedure in an early way, under 24 hours after we identify this condition in the patients. The second procedure in acute pancreatitis is in cases with patients with gallstone pancreatitis, but when complications such as cholangitis is associated. the procedure indicated is the spirorectomy. And this is important also to identify it like in an early way to indicate this procedure in all the cases with this. Now we have the risk reductions and the follow-up care in patients with acute pancreatitis. And here we have the cholecystectomy that also needs to be indicated like in an early way. This is a safe procedure, and it's important because shortens the hospital stays in patients with a predicted mild course of acute pancreatitis. And it's important to make it because it can reduce recurrent events. The indications for a cholecystectomy in patients with acute pancreatitis are first the OC treatment, the encompassing symptomatic gallstones, the cholecystitis, and pancreatitis. But why is the laparoscopic cholecystectomy more recommended under the open surgery? Well, according to the Tokyo Guidelines 13, here indicated that the laparoscopic cholecystectomy can reduce the discomfort at incision sites. This procedure is a shorter hospital stays and recuperation times. And finally, this procedure can improve the quality of life in all the patients with acute pancreatitis. But first, before we perform this cholecystectomy, well, it's important to evaluate all the patients with moderately severe and severe acute pancreatitis if they don't have like a peripancreatic fluid collections. And we can evaluate this by performing a constructed CT or MRI examination. And this is important to do it because the peripancreatic fluid collections, if we perform a cholecystectomy, this can get infected. So it's important first to evaluate these conditions, and then we indicate the surgery. And now, well, to conclude this presentation, I would like to tell you like the keys of the management of acute pancreatitis. First, like I said, it's important to start the intravenous fluids in the first 24 to 48 hours in all the patients, because all the patients with a severe and moderately severe acute pancreatitis are considered with fluid deficits. Second, it's important also to control the pain in all the patients with abdominal pain for acute pancreatitis. Third, patients with moderately severe and severe acute pancreatitis, the indicated of nutrition is the enteral nutrition. Four, in patients with gallstone pancreatitis, the procedure indicated in these cases is the ERCP. And if the patient have any complications such as the cholangitis, well, the spirorectomy is the indicated procedure. And finally, the cholecystectomy should be performed in all the patients with acute pancreatitis after they recover in association with gallstone pancreatitis. Thank you.
Thank you so much, Nicole, for your presentation. The management of acute pancreatitis sometimes can be difficult for us or even confusing, but with your presentation, I think it got very clear. Okay, for now, we're going to have a little coffee break, so see you in 15 minutes. Coming next, we're going to have the presentation of Ana Barón, that it's titled Facial Trauma, the Management for Emergency Physicians. See you then.
a practicar con el clicker. Yo no sé usar esto. Ya. ¿De dónde me agarro para bajar?
Good morning, everyone, again. Hope y'all enjoy your coffee break. So now we're going to be back with our first student surgery symposium. Now we're going to have the presentation done by Ana Barón that is titled Facial Trauma, Management for Emergency Physicians. And I may remember you all the QR code for your assistance. Thank you.
Hey, good morning, everyone. Is it a pleasure to be here with you, with every single of you? I'm Ana Barón, a fourth-year medicine student, and I'm here today to talk about facial trauma, management of emergency patients. Without further ado, let's start with definition. What is a facial trauma? Facial trauma is a bone or soft tissue damage to face caused by motor vehicle accidents, assaults including gunshots, chemical exposures, and falls, maybe chemical or thermal burns too, and animal bites. According to the epidemiology, we have that it represents one of the most important health problems worldwide. There is a male predominance with highest incidence in the age group of 20 to 4 years old. But there is also a difference in the prevalence of facial trauma because according to the age range between adults and pediatrics, because our bones doesn't have the same plasticity than pediatrics. So pediatrics are not included in this presentation. With anatomy, we can say that human face is an intricate area containing many bones, nerves, blood vessels, muscles, and sensory organs, and if untreated, facial trauma may cause a permanent loss of function of that, like seeing, chewing, speaking, and swallowing. Then we can have a disagreement if not treated at all correctly too. In this image, we have the main bones of the face: frontal, temporal, ethmoid, nasal, maxilla, mandible, parietal, and zygomatic bones. Have a very careful management of this patient, of injured this type of patients, is very imperative in these cases. This is why we have this item before patients arrive. There is a critical aspects of hospital preparation, including the following. Number 1, a resuscitation area that is ready to use for trauma patients. Number 2, warm intravenous crystalloid solutions. Number 3, properly functioning airway equipment. And number 4, a protocol to summon additional medical assistance. This is so important because we have to know when and how to refer our patient to another one person. In initial assessment, we have the ABCDE. These cases is followed by the ATLS, management of trauma. So we'll start with A, airway maintenance with restriction of cervical spine. This is, for me, the most important point in this conference of this type of patients. Number 2, B, breathing and ventilation of the patient. C, circulation with hemorrhage control. D, disability assessment of neurologic status of the patient. And E, exposure and environmental control. Restriction of cervical spine motion is maybe, the most important point in here today, because we have to take a great care to prevent excessive movement to cervical spine to prevent an more worse injury in the patient. Based on the mechanism of the trauma, this case facial trauma, assume that a assume that spinal has an injury exists. Here we have a video with a cervical spine motion restriction technique correctly. Please pay attention to this. Continue with the airway maintenance. We have that first, we have to assess the airway of the patient. We have to look for obstruction, and obstruction includes foreign bodies on the mouth of the patient and other injuries that can result in an airway obstruction. This is simultaneously we have to do an aspirate of secretions of the mouth of the patient. Establish an airway surgical if intubation is contraindicated and or can be complex. We have to know that it's so important. Don't do excessive movements with the patients immobilized because we can't paralyze the patient. So here we have a video with a great technique to evaluate or reassess the patient. Continue. It is important to say that an airway patency alone does not meaning of great or correctly ventilation for the patient. So we have pitfalls and how to prevent that pitfalls in these cases. We have that possibility of equipment failure, how we can prevent. Test equipment regularly and ensure spare equipment and batteries are ready to use at the moment the patients arrive with us. Unsuccessful intubations. We have to identify our patients with difficult airways. Identify the most experienced manager on your team and choose him. It's not battle that choose another one to do the management if they're the best or better than us. And ensure appropriate equipment is ready to rescue the failed airway element. C, circulation with hemorrhage control. Circulatory compromise in trauma patients can result from a variety of injuries like blood volume, cardiac output, and bleeding are the most measuring important cases to consider here. Definitive bleeding control is essential along with appropriate replacement of intravascular volume. So we have to take an intravenous of the patients and start to give him some solutions. It's important to say that aggressive and continued volume resuscitation is not an alternative definitive for definitive control of the hemorrhage. We have to know that if patient doesn't respond at initial therapy, we have to do a blood transfusion immediately. D, disability. Assessment of neurologic status. I'm sure that every one of here knows the GCS score. It's like the most simple and quick and objective method determining the level of the neurologic injuries in the patients. And we have to take it clear or take it printed that Every GCS less than 8 needs an intubation or management of the airway quickly. E, exposure or environmental control. Pitfalls, we have that the principle here is hypothermia can be present on admission, and hypothermia may develop after admission. It's the same management. We have to ensure a warm environment, use warm blankets and warm fluids before administering. Next, finally, we have a sequence of initial assessment on facial trauma. We have to do, we have to think and act like simultaneously with this. We start like anamnesis, quick questions like what happened, where happened, how happened. Then cervical immobilization is the most important in these patients. Every facial trauma is associated like craniocephalic trauma too. So we have to think about spinal injury in the patient. Then expirate secretions of the patients. Take a vital signs and take the patient's peripheral line and administer fluids. We have to look for rebleeding, and if we don't look or there is not a rebleeding, we have to take a greater airway and airway mask back to do the famous embout. If there is rebleeding, we have to endotracheal intubation or management surgically. At conclusions, we must bear in mind that we encounter stable patients or patients between life to the death. We have a patient like talking, walking by herself, but a few minutes, they can be worse. We must act simultaneously. We have act and think. And any Glasgow Coma scale score less than 8 requires intubation. Consciously, we have to raise the patient like 4 minutes, 5 minutes, it doesn't matter. We have to resist the patient. And this is important item. Sutures are not a priority in these patients. We don't have to suture or repairing or intervene the patients with, like, we're not surgical, plastic surgical, so our work is just save the life patients to refer another specialist. This is all. No sutures, no more interventions, because we're only general medicals. Thank you.
Thanks, Anna, for that amazing presentation. The correct way to manage the facial trauma is something really important for us as physicians. It is something we could see on our daily basis, so the correct management for it, it's pretty important. Now we're going with our last presentation by Luisa Melo. That's called Facial Trauma, How You Should Handle the Airway. Thank you.
Hello, good morning, colleagues, friends, and professors. My name is Luisa Gabriela Melo. I'm a 4-year medical student at Universidad Simón Bolívar Barranquilla. I hope you have enjoyed the symposium and the information that has been provided today. I will be talking about facial trauma and how we, as general doctors, should handle the airway. So, starting with the anatomy of the airway, it's really important to know that recognizing the normal anatomy of the airway and its different variations enables the physician, in this case us, to frame the best approach to every case scenario and every patient. The airway is divided into 2 portions. For today's purposes, we are going to focus only on the upper portion of the airway, which starts with the nostrils. The clinical importance of the nostrils relies on the fact that the roof of the nostrils is the cribriform plate, which in the context of facial trauma may get injured. This is really important because we should always avoid the nasal approach of the airway when it comes to facial trauma. But why should we avoid the nasal approach? Well, because if the cribriform plate is broken or fractured, there is a high chance that the airway device might go inside the skull of the patient and cause neurological damage. So we should always prevent and avoid assessing the airway through the nasal cavity in a facial trauma case. Following with the oral cavity, this is the preferred approach. Basically, its limitations are the tongue, the soft and the hard palate, the uvula, the tonsils, and the epiglottis. These are some of the structures that we should take into consideration when performing the orotracheal intubation. This cavity connects with the oropharynx. The pharynx is a muscular tube. It is really important to know that the wrong collocation of the orotracheal tube may provoke the avulsion or the rupture of the oropharyngeal aponeurosis, which can lead to pharyngeal dissection. So we need to learn and we need to know how to correctly put the orotracheal tube in order not to cause more damage to the patient. So today, the important focus of the conference is how to handle the airway. We, as general doctors, are only responsible for the ER management of the patient. We are not specialists yet, so we need to focus on saving the patient's life. So how are we going to save the patient's life? We need to assess the airway. We need to confirm that the patient is correctly ventilating and breathing. So how are we gonna do this? How do we identify the predictors of the difficult airway? There are some items that I highlighted here in the slide. As you can see, some predictors are cervical spine injuries, which we should always take into consideration when it comes to facial trauma. As you know, facial trauma is also considered as cranioencephalic trauma. So we should always suspect that the patient has a cervical spine injury. Also, severe arthritis of the cervical spine, which can be predicted in elder patients. Significant maxillofacial or mandibular trauma, when it comes to massive facial trauma and massive facial fractures, we should take into consideration that there might be a difficult airway approach. Also, the limited mouth opening and some anatomical variants. There's an easy and quick mnemonic method named LEMON that can help us to identify some of these predictors. The letters of the LEMON method stand for the next items. The letter L stands for look for features. We should always evaluate the patient's anatomical variants and features, such as the length of the neck and if the patient is obese or overweight, or if the patient has a different configuration of the face or the mandible length. This is really important to assess in order to approach in a better way the orotracheal intubation. The letter E stands for evaluate 332. This means that we should evaluate if the patient can fit 3 fingers between the 2 incisors' teeth, 3 fingers between the thyroid gland and the hyoid bone, and 2 fingers between the thyroid cartilage and the cricoid cartilage. This is to measure the length of the neck and the mandible of the patient. The letter L stands for Mallampati. I think we all know that Mallampati is a difficult airway classification, and class 1 and 2 of Mallampati indicate a good access, and on the other hand, class 3 and 4 Mallampati indicate moderate to severe and difficult access to the airway. So we should always take into consideration the Mallampati of the patient. The letter O stands for obstruction and obesity. This means that we should always evaluate the presence of foreign bodies inside the oral or the nasal cavity of the patients, and we should remove every foreign body or object that may be obstructing the airway. Also, we need to look for signs of overweight and obesity, since we know that overweight can also obstruct the airways of the patient. And the last letter, the letter N, stands for neck mobility, which I think is one of the key items or one of the key steps when it comes to managing the facial trauma airway. Because as we know, the neck may get also injured. There is a high chance that the spinal cord might get injured during the trauma, so we should learn and we should know how to correctly manage the neck of the patient. So continuing with how to handle the airway, we know the algorithm for the trauma cases, which is the ABCDE, explained on the ATLS. But today, for the purpose of this presentation, I will be focusing only on the A and the B letters, which stands for A, airway, and B, breathing. So as we know, maxillofacial or facial trauma is always considered as difficult intubation cases because there are many bones that get injured. We have a lot of bleeding because we have like a lot of blood vessels irrigating the face. So it might get really difficult to intubate the patients because of all the secretions and all the bones that may get compromised during the trauma. So this is an algorithm. So we are going to evaluate the letter A by asking a few questions. We are going to evaluate the permeability of the airway and also the neurological status of the patient. How are we going to do that? We are going to ask a few quick questions to the patient, such as, what happened? When did it happen? Do you have any allergies? And do you have any comorbidities? These questions are going to help us to determine if the patient's airway is permeable, and also are going to help us to determine if the neurological status of the patient is conserved. If the patient is able to answer at least 3 of these questions, then it means he's correctly ventilating and the airway is permeable and that his neurological state is functioning correctly. The next step is the neck immobilization. We are going to perform neck immobilization using an orthopedical Philadelphia neck. The maneuver, I'm going to show it later on the next slide. Then we're going to aspirate the secretions. As I was saying before, the face has a lot of blood vessels, so any trauma that is caused directly to the face or to the neck is going to result in a lot of bleeding. So we need to aspirate all secretions, blood and mucus, from the airway of the patient in order to intubate and assess correctly the airway. Then, after we finish assessing and aspirating all of the secretions from the both oral and nasal cavity, always take into consideration the nasal cavity, even though we are not going to put any devices inside the nose of the patient. We should always aspirate the secretions from both cavities. After we aspirate the secretions, we are going to evaluate if the patient is still bleeding. Why should we re-evaluate the patient? Because if the patient is not bleeding anymore, then it means we can continue the ventilation with a Guedel cannula and a ventilation bag that we know as an ambu. Or if the patient continues to bleed, then what we need to do is to perform rapid oral intubation of the patient in order to prevent the hemodynamical unstabilization of the patient. We need to stabilize the patient quickly because it is highly probably that the patient will go into respiratory distress, which we need to prevent in order to save his life. So this is a video taken from surgery for students performed by one of our classmates. This is the correct maneuver on how to immobilize the neck of the patient. We are going to apply a slight traction to the neck. We are going to avoid the motion of the head and the body. We should always avoid moving too much the patient because we don't want to cause more harm. We don't want to injure the spinal cord, which we have to suspect that is already injured. There is a high risk that we can paralyze the patient, so we need to immobilize the neck correctly. This is the first step and is one of the most important. We cannot assess the airway. We cannot put intravenous peripheral without immobilizing the neck. We need to do this first thing first. This is the maneuver, a picture taken from the ATLS manual. This is performed on the video. This is the correct technique for aspirating the secretions of the patients. This is a key step. It is really important when assessing the airway on a polytraumatized patient, since the secretions and the mucus and all the blood coming from the nose, the mouth, and the airway from the patient may obstruct the passage of the orotracheal tube. So, as it is shown in the video, we are going to aspirate the secretions, both the nasal and the oral cavity. But how are we going to aspirate? We are going to insert the cannula, the aspiration cannula, only on the gums and the base of the tongue. We are not going to go too deep in the throat. We don't want to put the cannula in the throat of the patient. We are going to cause more damage. We are only going to aspirate on the outside of the mouth and the roof of the tongue and the base of the tongue. The same applies for the nose. So after we finish aspirating these secretions, we are going to be presented with this question. Is the patient still bleeding? If the answer is no, then, okay. Necesito que le dé clic. If, okay. Sorry for the technical issue. I need you please to click on the, okay, thank you. So this is the question that we are going to be presented. If the answer is no, then we can assess the airway through the Guedel cannula. How are we going to put the cannula? We are going to introduce the Weddell cannula by following the curvature of the tongue. And then, when we are placed in the oropharynx, we are going to rotate the cannula 180 degrees. And after it is set, we are going to attach the ventilation bag and ventilate the patient. It's a really easy way to approach the airway when there is no rebleeding. And if the answer of the question is yes, meaning that the patient is still bleeding, then we have to be quick. We have to evaluate the airway, the difficulty of the airway, and perform a rapid oral intubation. We need to put an orotracheal tube inside the airway of the patient. But how are we going to do it? We are going to perform direct laryngoscopy using a laryngoscope. We are going to identify some structures such as the vallecula, the epiglottis, as is shown in the video. Those are the vocal cords, and that is the space where the tube should go. The tube should go between both vocal cords, following to the trachea of the patient. After the tube is set, we can continue ventilating the patient. But what happens if the patient keeps bleeding and we are not able to perform rapid oral intubation? What if the tube doesn't fit? What if the edema is too high that we cannot see anything? What if the patient is just too obstructed to put the tube on? What do? We have to prevent the patient going into respiratory distress. We have to save his life. How are we going to save his life? Then we are presented to this problem. We need to solve it quickly and on the easiest way because we are in the ER. We are not in an operating room. We are not surgeons. We are just general doctors, but we need to learn how to perform a surgical airway. This is an emergency procedure that is performed on patients when they are on respiratory distress and we are unable to put a definitive orotracheal intubation, or in this case, the nasotracheal intubation. So the next video that I'm going to show you is the correct technique to perform a surgical approach of the airway. This is a simulation that was performed in the simulation lab in the university. Volume. I need the volume on the speakers, please, for the video, because it has some explanations.
The cricothyroidectomy is an emergency procedure that is performed on patients with respiratory distress wherein you, as care provider, cannot obtain a definitive airway via orotracheal or nasotracheal intubation. Some indications of cricothyroidectomy are very difficult anatomy, class 4 malampari, short mandible length, obesity, limited neck mobility, and sleep apnea. Presence of excessive amount of secretions in the airway, food, or foreign bodies may obstruct the space where the orotracheal tube should be inserted. Facial trauma can physically obstruct the airway and complicate the intubation process. Take this man as an example. He was walking peacefully down the street when a car hit him out of nowhere. He was brought to the ER where there were performed multiple intubation attempts and the patient went into respiratory distress.
I'm having trouble bagging him. There's a lot of resistance.
His oxygen saturation is dropping.
I'm going to take a look. Can't see anything. The cords are swollen shut.
His pulse is dropping, guys. This doesn't look good.
Grab me a scalpel and a bougie.
The best option is to perform a surgical airway, but where to cut? The main structure that we need to locate and remember is the cricothyroid membrane, which is the point of interest where we should make the incision. It is located between the thyroid cartilage superiorly and the cricoid cartilage inferiorly. Now that we know the landmarks, what do we need to save this patient's life? We only need 5 essential things: a scalpel, tracheostomy cannula, a bougie, a pediatric orotracheal tube, and ventilation bag. Now we are all set to start our surgical airway. The first step is to apply a slight traction to the patient's neck to get them to a sniffing position. Next, we should look for the cricothyroid membrane located between the thyroid cartilage and the cricoid cartilage. Make a vertical incision in the spot where the membrane is located. Afterwards, we should introduce our fingertip or the posterior tip of the scalpel to dilate the space to introduce the cannula. Next, introduce the bougie previously attached to the tracheostomy cannula. Hold the cannula in place and take the bougie out. Finally, we should attach the ventilation bag and we are all set to ventilate the patient.
Okay, as it was shown in the video, this is the correct technique to assess the airway of the patient on a surgical way. If we don't have a tracheostomy cannula in the ER, we can use a pediatric orotracheal tube number 6 or the less number that we have available. It's not necessary the cannula. Okay, to finalize the conference, these are some conclusions that I would like to highlight to end the presentation. First, we should always recognize the anatomy to perform a correct approach of the airway. Second, the method Lemon is an useful and a rapid aid in the ER in the attention of trauma patients. The third item that I would like to highlight is that getting to know or to familiarize with the traumatic airway algorithm can actually save a life. We need to learn the algorithm. It's the only way to save a life. We need to be mechanical and we need to do this quickly because it's a life, what we are talking about. We need to save the patient's life. It's our only purpose. Fourth, do not forget to immobilize the neck of the patient and to aspirate the secretions. These are the main steps: immobilize and aspirate the secretions. If we don't do this, we are not going to be able to perform a rapid oral intubation. The intubation may go wrong. And fifth, but not the least, always reevaluate the patient's neurological and ventilation status. These patients can go to a less level of consciousness and ventilation in just a few minutes. So we need to keep re-evaluating the status of the patient, even if it's already stabilized. Thank you so much for your attention.
Thank you so much, Lisa, for that amazing presentation. So we have just looked at the management of the airways, the most important step in the management of the facial trauma. For now, we have finished our presentation segments, and now we're going to be here for a couple questions. You can scan here this QR code, so you can leave your question. We're going to leave it for a couple minutes, so make your questions.
Good morning, everyone. Well, first, I'd like to take a moment to thank everyone for attending to this symposium. And of course, I want to express my gratitude to the doctors for providing us this platform to share knowledge at this significant event. I would also like to extend my thanks to our amazing speakers for the excellent presentations that we have the privilege to hear today. As you know, we covered a range of important topics in this symposium, but now it's time to engage our audience. We'll now move into the questions and answer session where you will have the opportunity to interact with other speakers. So please feel free to share your comments, your questions, or reflections. You have to remember that we're here to discuss and learn together about these fascinating topics. In the QR code that you're watching on the screen, you can scan it and write the question that you want to do to the panelists. You have 10 minutes to do your question. Thank you. Espérate que yo creo que se lo mandé a Nicole. No, esto no es, mierda. Bueno, no importa. Así que yo te dije como invitada. ¿Yo dónde se los envié a ustedes? Yo se los envié a sus correos. Vayamos hablando ya, ¿no? Ok, vamos a iniciar. Pero... Ay, quédate aquí conmigo.
In which case you should use a tag for acute pancreatitis?
La pregunta. Y no las que tenemos aquí.
Sí, también.
O sea, 3 preguntas para Lina. Okay. Y... ¿Quién fue el sapo que me puesto eso?
Para ver si es Symposium. Right. ¿Dónde está? ¿Vale?
Está abajo. Hicieron 2 preguntas. No sé quién fue el sapo que decidió.
Tres para Luis, 2 para Ana, 2 para mí.
Ponme la de Lina. Señora, ¿me la pones? Entonces voy a iniciar ya. Hello, silent please. Thank you. Now we are going to start our questions for all the expositors. The first question we had in the form is for clinical approach to the patient with acute pancreatitis by Lina Vasquez. So the first question we had in this form is, what is the cardinal symptom that indicate acute pancreatitis?
Okay, the cardinal symptom in the acute pancreatitis is abdominal pain. I said in this conference that abdominal pain have acute onset, severe epigastric and left upper quadrant abdominal.
Okay, thank you so much. The second question we have for you is, which is the best score to calculate mortality and do follow-up on patients with acute pancreatitis?
Okay, in the personal opinion, the studies have demonstrated that the better is a BISAP score for the early mortality and more or less than time.
Okay. And the last question we have in this form is, in which cases in which cases should we use a tag for acute pancreatitis from diagnosis?
Repeat, please.
In which cases should we use a tag or TC for acute pancreatitis for a diagnosis?
Okay, is two criteria. The first criteria is the severity of acute pancreatitis, and the Apache score is more than 8 points.
Okay, thank you so much. We're going to pass to another questions.
Okay, so the next questions we're going to have are for Nicole Monsalve and her presentation about medical and surgical management of acute pancreatitis. Okay, so the first question is, when is it ideal to perform a laparoscopic cholecystectomy in patients with acute pancreatitis?
Okay, it's a good question. Well, according to the updated guidelines of the American Gastroenterological Association, the right moment to perform the laparoscopic cholecystectomy is right after the patient recovers, and it is indicated in all the patients with gallstone pancreatitis. Thank you.
Thanks for your answer, Nicole. Now, second question is, considering the fact of the analgesics mentioned above, which one will be the most indicated for the pain management in acute pancreatitis?
Okay, like I said in my presentation, according to the guidelines, the recommended analgesic to use in patients with acute pancreatitis are the intravenous opioids, well, especially the hydromorphine and fentanyl. But, well, in the update of the studies, there says that most of experts use the fentanyl because it has like a safe profiles in all the patients, and especially in patients with a renal impairment. Thank you.
Thank you so much. Thank you so much for your response.
Hello, Anna. How do you feel?
Hi.
Okay, Anna. My first question for you is, on the initial assignment, what is important the cervical immobilization?
Okay. Why it is important cervical immobilization?
Yes.
I think that I don't want a paralyzed patient. We have to be careful to manipulate this patient, and we have to take clear that this trauma is associated to cranioencephalic trauma too. So we have to assume that there's an injury or damage too much or so difficult to manage. So we have to have a very careful management of these patients. This is why this is important, cervical immobilization.
Thank you, Anna. And my next question for you is, what is the initial priority in the management of a patient with facial trauma?
The answer of this question is very obviously. I told in my presentation that the most important point of my conference in these patients is cervical immobilization for by the patients, and we have to take it present to the management or airway. But I want to say that we have to act quickly, but not running. We have to think and be clearly, be calm, be peaceful because there is a life to save. So we don't have to run, we don't have to do things that we don't have to do. We're general medicals and we just have to save the patient's life to refer to another specialist.
Okay.
Thank you.
Thank you so much. And our last questions are for Luisa Melo and her topic, facial trauma, how you should handle the airway. So the first question for you, Luisa, is what are the main characteristics of a difficult airway?
Well, as I said in my presentation, facial trauma is one of the indications of the difficult airway, but some other indicators of the difficult airway are obstruction by large masses, by foreign bodies, some anatomical variation such as short neck, the length of the mandible, and also if the patient is overweight or obese.
Okay. The second question for you is, do we need to handle the airway even if the airway looks like it's not compromised?
Well, as we know, the correct algorithm to treat the traumatic or the polytraumatized patient is the ABCDE. So in every trauma scenario, we need to handle the airway, even though if it doesn't look compromised. And also, we need to take into consideration that the patient's neurological and ventilation status may go down really quickly and easily. So we need to reevaluate the airway every time we reevaluate the status of the patient.
Okay. And the last question the public asks to you is, cricotirotomy can be performed by a general doctor or we need to ask for help?
Well, we need to perform emergency cricothyroidectomy if necessary. We are supposed to be trained to perform these emergency procedures in the ER. We cannot wait for a general surgeon to arrive. If we call a general surgeon or an anesthesiologist, they may take 30 minutes, an hour to arrive to the ER. The patient is going to be sadly, most likely dead when the specialist comes to the ER. So we as general doctors need to know, we need to be trained, and we need to learn how to save the life. It's our only purpose.
Thank you so much.
Well, this is the last question, and it's for all the panelists. For this question, you have to give your opinion. And it's, what do you think these academic spaces are important for us as students?
I'm sorry, can you repeat the question, please?
Of course. What do you think these academic spaces are important for us as students?
Okay, I think that this academic space is a great opportunity to us, like medical students, to learn and remember like all the topics that we saw during this semester. And I think that a lot of you here have a great potential for being in the next editions of these kind of events. So I think that in future events we are going to be better, we are going to improve, we are going to look for different topics that concern us as medical students. And I hope that in different editions I can see a lot of you here, and I'm so grateful with the doctors to give us like this opportunity to be here and perform well this presentation. Thank you.
Well, I think this is a great space, an educational space for us to learn. This is our first conference ever. and it was a high challenge to do our first conference in a different language that is not the language that we usually speak in our daily basis. So for us and for myself, I think it was a great opportunity to learn, to explain some of the most common topics in the ER that we should know and we should handle as general doctors. I think this was a great opportunity, and I think this is really good for us to learn how to face a crowd and a scenario, and for us to learn, because I think we have a lot of potential to be international conference.
Well, this is my first time talking to a public, so I'm so nervous. I'm panic right now. But I think that this space is so special for me and for one of my classmates. So I think that this is more than academic formation. This is an integral formation. It's myself of every one of us, every single of us. So it's a great opportunity to be here. Thank you for paying attention, for listening, even if you can't understand at all of every presentation, but okay. This is a great space for us, to students, for our teachers, doctors. Thank you to Dr. Ivan Rubio for gave us one of the most important sequences and the most easy form to understand the sequence for facial trauma management. And thanks to Dr. Maria Cristina for gave us trust to us for be here in front of every one of you. So thank you.
Hola. Okay, I consider that this space is very important for the student, for the explain and the files. I consider this space is presenting is the opportunity of the area, different area in our career. Thank you.
We thank the speaker for answering the question for the audience. Now, to conclude this event, we invite Dr. Ivan Rubio, plastic and reconstructive surgeon for the University of Caldas and professor of clinical simulation at the Simón Bolívar University, to present the final speech.
I want to speak English, like you and you and you and you and you. Ay, hombre. We want to say thank you to Simón Bolívar University for this space, for our director, Dr. Ricardo Escobar, Ricardo Escobar. Yeah. Okay. I am seeing very happy and proud face in this table and here. And the next year, I want to see two women and two men. Okay? The next year. Okay. Today we mark a significant milestone in our history. For the first time, we celebrate these events in language that is not ours, demonstrating our ability to adapt and overcome barriers. I want to congratulate you with all my enthusiasm. They have showed that waiting and power, and they have done it exceptionally well. Congratulations to each of you for achieving this important milestone. They have shown that with determination and effort, it is not only possible to achieve our goals, but also to advance things to glimpse the future, a future that you are prepared to lead and transform. Guys. This is my wife, my chief. Guys, you can see the future, your future. You can see. Invent it. Okay? Invent it. Thank you.
Abajo.
Pongámonos abajo.
Algunos jóvenes se pueden sentar aquí para que no se despasillan así aquí. No, ustedes aquí delante. Muchachos, llenen las sillas.